basically, the problem, there's no urologist that believes that the screening recommendation should have been an A or a B, because the data on screening is very confused, and there isn't any study that's really good. We've got a lot of epidemiological data that's pretty vague. What seems to have happened is that the USPSTF weighted a study called the PLCO study, as opposed to another study called the ERSPC. I don't want to get into the study alphabet soup that was there, but there are two big studies that directly contradict each other. The problem with and they're both flawed. So most urologists believe that since both studies were flawed and it was contradictory, we should get a C recommendation, which is we just don't know yet, it needs further study. But what the PLCO to give you an idea, and I asked this question, I'm going to ask it to the room, okay? So if you were going to design a study to evaluate PSA screening, the effect of a screening test, you would say, on one hand, I would screen patients, and the other hand, I set out, you wouldn't screen people. But the PLCO study didn't do that. The PLCO study said, we're going to compare screening against something called usual therapy. Because in the United States, PSA testing was fairly ubiquitous. And so what it turns out, that in the original publication, which the USPSTF hinged its recommendation on, you had one group of patients that got screened, and another group of patients that got screened 55% of the time. So you compared screening against 55% screening. And go figure, you didn't see that much of a difference compared to the European study, which was very dramatic. What we just recently found out, just in June of this year, and we can supply that literature, is that the data contamination in the control group in PLCO wasn't 55%, it was 90%. So the USPSTF hinged it, and we don't know how they weighted it because they don't tell you, they just say that we looked at these studies. They based this decision that's affecting the lives of tens of thousands of men on a study that compared screening against 90% screening. Which is why, when Serge and I look at the data, we don't come to the same conclusion as people that never treat prostate cancer, because we say, this just doesn't make any sense. You can't make a decision on this. Which is why you need to have experts on the field, people that take care of cancer, people that are involved in the disease, helping the epidemiologists understand the numbers that they're looking at.
Yep, fully agree. Additionally, they looked at the benefits of screening and they balanced them against the harms of treatment. Well, the harms of treatment comparison is historic, right? Because they consider patients that would have basically non-aggressive, nuisance type rather than a risk type prostate cancer, and those patients undergoing aggressive treatment. That's hardly ever done anymore. Over 50% of patients with low-risk prostate cancer are no longer treated aggressively. They're on approach that this man has undergone, which is active surveillance, where you simply closely monitor the disease. So you are improving your screening with these new technologies, multiparametric MRI, genomics, proteomics. You're improving your screening value, and you're decreasing the morbidity of the treatment. So both things are working in favor of offering screening, whereas they kind of took the worst view of the screening and amplified the morbidity of the treatment, which is no longer applicable in the modern treatment of prostate cancer.
Any final words from Dr. Knapp or Mr. Sabbs?
The only thing I would add is that also looking at the different studies that have been referenced, the prostate cancer, there are a significant percentage of prostate cancers that are slow growing. They take a time to develop and affect the patient's life and health. And the initial studies that were looked at were younger studies. They're looking at 7 and 8 years of data. Studies that were the European studies looking a little longer at 10, 12, 14 years of follow-up. You start to really see the benefit of PSA screening. So that data hopefully would be looked at more accurately. Previously, again, was either missed or ignored. There was a significant difference.
All right, great. If we can give a round of applause to our panelists, please. Thank you all for joining us. Also want to thank our partners from the Foundation of Breast and Prostate Health, and also our friends who are present today from ZERO, the American Urological Association, and LUGPA, who share in our concern about identifying prostate cancer and providing appropriate treatments if needed. So
Can I thank Men's Health Network
Oh.
for their undying commitment to this issue. And it's because of that kind of advocacy that we're able to even have this discussion. So thank you so much.
Thank you, Daryl. Once again, we want to thank our congressional sponsors from the Men's Health Caucus, Congressman Markwayne Mullin and Congressman Payne Jr. and their offices. And thank you all in the audience for coming and sharing in this topic and asking your questions and participating. Have a wonderful day.